Hello, everyone. Welcome back to Red Velvet Talks. We are bringing in the new year with a bang this year, okay? 2026, here we come, okay? I'm so glad to see you all. Welcome back, everyone. Thank you again for supporting me. Today, we have a great topic. We're talking about healthcare and advocacies. And I have believe it or not, my old boss great friend, and my realtor, all packed up in one right here. I call her Diva. This is Salea Andrews. Welcome to Red Velvet Talks. How are you today?
I'm good. Thank you so much.
You're welcome. You're welcome.
Yeah.
You look great.
Yeah, I'm just like you look amazing. And it's really good to be with you.
Yes, it's hard for the two of us to get together. So we're always doing a hit or miss.
Yeah.
You were supposed to come on not too long ago, but then you ended up not feeling well.
Yeah.
And of course the flu and COVID and everything else is getting everybody right now. Yeah. And it has been crazy.
Yeah.
Health-wise. So I'm glad that we are discussing healthcare today.
Yeah. I was gonna say a lot to talk about. It's good.
Yes.
Yeah, because
So Salea is an RN. Well, actually, Talia, you tell everybody about yourself because you have a long list. Okay, she does everything. So tell everybody what you do.
So streamline it down. So my background is in nursing, healthcare. I like to focus on more of the patient advocating side, like what healthcare should look like for us, our community, us, right? And with that being said, really just like to put a focus on having people put their own hands on our specific healthcare, like individually, how we gauge, how we speak for ourselves, how we understand what the system is offering us or not.
Okay.
There's a resilience in understanding that there is like, like some barriers in healthcare, right? And so there's so much healthcare available to us, but what does that really look like for us individually? So I really like to spend a lot of time on the healthcare advocating side and just really making sure that families have all the resources that they need, and understand what those resources look like and how they should apply to our individual health needs. And then on the other side, because I did some pharmaceutical way back,
didn't know that. Okay, go ahead.
That brings in like the marketing side, right? And so that's where the real estate came in by accident.
Okay.
But interestingly enough, what I find is that real estate and healthcare have an interesting mesh.
Oh, okay.
Yeah, because I'm finding myself involved with families at the two most important times of their lives, either on the healthcare side or making some decisions about where they live or not, right?
Okay.
And so both of those intimate areas, and I really love that mesh. And just anytime I'm in real estate, I'm trying to make sure people, like, do you understand healthcare? Do you have a long-term healthcare plan? What's your plan when you move out of this house? What's the downsizing all about? So it's a very interesting niche that other realtors don't have.
Okay.
And then when I'm on the healthcare side, I typically don't bring real estate into that because,
yes.
Yeah. So kind of stay there.
Because you also, I think a friend of my dad's, you actually because you have also an agency in which you can send nurses
out to. Yeah. So the goal of that, we call it, when I developed it, it's the caregiver at home.
Okay.
And so the goal, Caregiver at Home LLC, that's us. But the goal was to be able to assist families when they had their loved ones that needed in-home care.
Okay.
To help them, give them some training, like to be able to have the skill set to do their ADLs, right?
Okay.
To get their loved ones ready for the morning, to be able to dispense those medications, to be able to work out like a home care plan that they would put their own hands on.
Okay.
So, and we do it in a sense where we go in and we train families, if your loved one needs round the clock care, when do you really need this care? Is there another relative that can assist? How much can you do? So I try to go in and give families the basic training. But out of that, what you'll find a lot of times is just because of the normal hustles and bustles of life, families really need to work. So we get more of people wanting to bring caregivers in the house.
Okay.
So it's a twofold. But ideally, the goal was to go in and teach families how to be caregivers at home so that they could cut down on some of the expenses that cost, because it's just not affordable to everyone to get 24-hour care at home.
That is true.
So we trained families then, and that evolved out of having, like yourself, a loved one in the house that I had to provide care for.
Right,
so,
right.
Yeah.
Because even with Noelle, yes, I understand the hustle and bustle and you trying to take care of a loved one, and working, and how do you go to work? How do you make sure they're going to be okay during the day?
Yep.
And then as his health declined, of course, as you know, I had to place him, which was the hardest thing for me to do. And I know you remember that call that day, me crying when I had to place him.
Yeah.
Because that's difficult. But with me placing him, I was there often.
Yeah. Yeah.
And that's something that you have to do. Yeah. So I did not announce when I was coming. I often did surprise visits. There was times that I would show up in the morning before I went to work. If I got off of work, early, I would show up in the midday. Show up in the evening, also my aunt Barbara, who was very helpful. She too would just randomly just show up. And I think it makes a big deal if you randomly show up and them not knowing when you're showing up, because unfortunately in some of these facilities, they don't give you the care, or they don't have enough staff to give your loved ones the care. And it's better when you are able to have that one-on-one in the house, if you can afford it, and if it's something that
if it's and that's because it's so like multidimensional, right? Because you have there are some families that just cannot afford that process of being able to place their loved one somewhere in the community, and so they have to rely on like home to do it. Or some families that just don't want to trust that process, because like for yourself, you monitored along the way. You
still didn't trust it, but
right. But it was a system that you had to use, and so and so and it's a balance to it. But everything, all the steps that you took to ensure that there was proper care. I mean, the pop-up visits, the unannounced, like changing the schedule. Those are all like just great ways to make sure that you're advocating for your loved one, and then have some spot on, like actually seeing what's happening.
Right.
And then on the, for the other circumstances, when you have families that just cannot place, or they haven't gotten to that step, then you have to bring that you're really bringing like that facility into home.
Right.
And sometimes it does involve even like having, if we place a caregiver in their home, then you're bringing a stranger into your home, and that's a whole nother dynamic.
Yes.
Right.
And you got to put up cameras.
You gotta have cameras.
Maybe. Yes.
Background checks.
Yes.
And sometimes all those things don't play out the way that it's supposed. It's not a perfect system. The family member that's supposed to come at 11 o'clock but doesn't come, right? That kind of drops off during the whole care process. But it's just many dimensions to it.
Yes, because and actually I ran into my dad's friend, and he just said how much he loved
that
the girl that you sent to help his mom. So he really, and that worked out perfectly.
She wasn't so anyone that and I think you and I talked about this before, that anyone that I'm going to send to a family, if I'm connecting you with that family, like it's many years of experience.
Okay.
And it's a full trust process.
Okay.
And I have to have like observed how they work and know that like I'm not just pulling a name out of a hat, an agency call. Like it's a real connection.
Okay.
So and with that family, that was particular because the mom, he relocated his mom here to be with him.
Correct.
And so it was almost like he entrusted that caregiver so much. So I believe that caregivers is important to develop like you're important dynamic of the family. So you almost need to be a part of that family without crossing any barriers.
Right.
Of being unprofessional.
Right.
And making sure that what you're presenting is what the family wants.
Exactly.
That it's welcoming to them. So
yes,
they were a nice family.
That's good.
That caregiver actually was in my home for a while.
Oh, okay. Okay.
Yeah, she was.
So then you were definitely spot on with that.
Yeah. Clean, professional. And would advocate for your loved one. That's the thing, because I remember with that caregiver, there was a time when my loved one had to be admitted to. We did like a respite care.
Okay.
I think we had a flood in the house or something one cold winter, and we had to take my auntie mom. I called. We had to take auntie out of the house and send her to rest because we lost our heat.
Okay.
For like 2 days before a contractor could come. And it was interesting. We had to use a facility, and that caregiver went in and she sat with her while she was there and made sure that everything that was being done at home, as much as she could for her care, she was there and involved in this. So
Now, me being an advocate on my own, I had to bring this out today. Me being an advocate on my own. So I was an advocate for my dad on my own. I had this book.
Yeah.
Everywhere I went.
Yeah.
Everything about that man and his health care is in this book.
Yeah.
So everywhere we would go, all the appointments, I'm sitting there with my pen and paper, I'm taking my notes, the medications, I'm following up with the emails with the doctors, and I had to stay on it. Anything that did not feel right to me, of course, I'm emailing the doctors, and that's another thing about being an advocate for a loved one that you're taking care of, is that you got to really pay attention to even just the little things. So it's almost, so in a sense, and thinking about it now, it's almost like when you have a newborn child.
Yes.
So you have a newborn child. If you see that something doesn't seem right with this child, the first thing you're going to do is, okay, I need to call the pediatrician.
Right. Yep.
So, and that's how it is when you're advocating for an elderly parent and or a loved one.
Right.
If you see something off, okay, I need to message the doctor. Let's possibly schedule an appointment. Things like that. And one case I'm gonna give you, I'll never forget my dad, and everyone, I call my dad Noel. If you don't know that, I call my dad Noel. His voice got very raspy. And I couldn't understand why his voice was so raspy. And this is going back to being an advocate and speaking out for loved ones. So I actually asked his primary doctor for a consult to an ENT. And I was told no. And I was told that he probably needs, is possibly acid reflux, have him to double up on his medication. That did not sit well with me. I said, okay. So 2 weeks went by. We still have this raspy voice. He's not getting any better with it. I messaged her again. I want a consult to an ENT.
Yeah.
And she still tried to, I said, no.
Yeah.
I want the consult to the ENT. So she did. She finally went ahead and put the consult in for ENT. I scheduled the appointment immediately. I will never forget that day. I could not go with him to the appointment, but my Aunt Barbara went with him. So they called me on the phone. So I'm on the phone with them while they're in the doctor's office. And so they said, well, we're going to scope him while he's here. So they went ahead, they put the tube down his throat just to see what was going on. And I hear the doctor say, you see that?
Yeah.
And they found cancer in his larynx. They found cancer. And that was the second time he has, had cancer. And from there, he had to have radiation treatment for 11 weeks every day.
So if we do a deep dive with that, like the thing that stands out to me immediately is that there was a recognition, right?
Mm-hmm.
And so you made the suggestion, and immediately on the primary care side, when you think about this person's past history, this
Mhm.
patient's past history,
Mm-hmm.
so we're, of course, first at hand, what they say in medicine, we start high and then kind of
Work our way down.
Yes. And first in hand, that should have been the steps like, okay, this is someone who had previously already had this type of diagnosis or issue.
Mm-hmm.
And so now we're bringing that up immediately. So now here you are a couple of weeks later. And finally we get there, right? After persistency on your part. And so that's, the importance of, if you're someone's advocate, being able to recognize all the small details, is paying attention to all the small details and don't dismiss them. And when we talk about that specifically with like the senior population, because they're not always able to express everything.
Exactly.
Right.
Exactly.
I think you and I talked about the episode where I had staff.
Yes.
And I said I was in a particular facility that we shall not name. We shall not name. But if you ask me, I'll tell you.
Call us later.
And the thing that I thought about after the diagnosis was confirmed was that, wow, some of the seniors in that space where I was, they can't advocate for themselves. And so what I experienced, the pain, the sickness, the hospitalization, how much of that gets overlooked because the patient cannot verbally speak or they can't express.
Exactly.
So it's so important. I just wish that like every patient or every person was so blessed to have like someone that was serious minded and would advocate for them and pay attention to all the small details.
Yes.
We hear a lot of that, like specifically with women with breast cancer, like the time that it takes from diagnosis to get ready to go see a specialist, taking off work, waiting for a referral. All those weeks go by. And that's typically what happens with the specialty services, right?
Right.
Remember back in the day, you could go to the emergency room for anything. And there was always like an on-call specialist. Like if they thought you needed ENT, they would just page one in-house, and those days are gone because our emergency rooms are pretty much functioning like urgent care centers.
Correct.
So it's only like the trauma.
Yes.
Some of those level 2s and level 3s.
And it's interesting that you said that because the last time Noelle was in the hospital, they were unable to insert a catheter. And they did not have a urologist on staff.
Yeah.
And they said that if we cannot get it in, just the emergency room department, they could not get it, they would have to actually transport him to another hospital because they did not have one on staff, which is very interesting.
It's very interesting. And the amount of money we pay for healthcare and only to increase.
Not a subject another day.
Woo!
Yeah.
That and we know that those services have been taken away from our emergency rooms, like prior to this whole like hoopla, all this chaos that's going on now. But I bet if we sat down and looked at the statistics of the way that they were running the ERs then, where you could get a specialist in-house to urgently like address some of those issues, the numbers would look a lot better than what we see now.
Yes.
Because now we see, like a patient goes to ER, a patient needs some type of specialty services, they're not going to get it. They have to
you have to get a referral.
Unless it's like really something trauma or what's deemed like whatever their hospital's criteria is.
Yes.
And they say, okay, we'll admit you, and then tomorrow or 2 days later, a specialist will make rent. So some of these healthcare corporations, you're sitting there. So that's why I think that, and specifically in our community, because we got to have like a lot of conversation, a lot of these talks, a lot of being comfortable advocating.
Yes.
And it's a whole process to it because sometimes also and you and I talked about this, we talk about this a lot. When you talk about what those family relationships look like before someone needs healthcare, right? So if it's not a trusted relationship, I'm not going to trust you with
To
all
tell you your information.
And so sometimes there are barriers there to break down, and everyone has them.
Yes.
For whatever. Yours might not look like mine, and it's very specific or family driven or relationship specific, but you have to have somebody that's advocating for you.
Yes.
Yeah.
Now I had one of my close girlfriends, Kelly and Carrie. So Kelly had breast cancer. Now she advocated for herself, but her sister, Carrie, crazy. She's a crazy advocate. Perfect. I mean, she literally was on top of things when it came to her sister's care, which is what she needed.
Yeah.
Because one, getting a diagnosis that you, because I believe, I want to say she's stage 3, HER2 positive. So Kelly, if I'm saying it wrong, I apologize. But getting that type of diagnosis, and then you're having to, okay, now I got to find a doctor. But one thing that Kelly did do is Kelly looked for her own doctor.
I like that.
Kelly looked for her own doctor.
Yeah. she
looked for what she thought would be good for her.
Yes.
And then she started her treatment.
Yeah.
Even though, she was, the stage she was in, it was still, she knew she had to get treatment fast. However, she shopped for her own provider from there. Yes.
Yeah, because she herself would know specifically what she needs. And, and that's the thing. And being comfortable enough to do that.
Yes.
Like connected enough to yourself to know that I know that one's not going to fit what I need. Maybe that one won't communicate the way I like to communicate. Presentation, bedside manner is everything.
Yes.
Right? And how effective is that going to be during my treatment? So that, because it's part of my healing process.
Yes.
Absolutely. Yeah.
Yeah, because you want someone who is going to care about you. You want someone who knows you, who's going to, again, advocate for you, who's going to fight for you when it comes to the insurance companies. And I'll never, another quick story, I'll never forget, I worked for Dr. Parkinson. This was years ago. And
so many years
I know it's okay. Hey, we've been in the medical field for a long time.
Yeah.
But I'll never forget, I remember her on the phone literally yelling at the insurance company for one of her patients because the patient actually had sleep apnea. And she was trying her best to get him the treatment that he needed. And they were like, no.
Yeah.
And I remember her and she was standing up in her office. So I knew and she's a very quiet, mild-mannered person. But to see her standing up on the phone and she's yelling at the insurance company, trying to get them to make this approval for this person because sleep apnea is not good.
Yeah. And there are certain equipments that are necessary.
Yes.
Right? Care plans.
Yes.
So knowing that you have a provider that's gonna also understands that you obtaining your healing is just as important to that provider as it is to you. And so, it's important to know that you're, receiving care or you're connected with someone. Because we have the thing about us in this DMV area is that we have a lot of good physicians here.
Oh my God, yes.
Yeah, we have like some major, amazing, good reputations. But that doesn't necessarily mean that just because that provider has like an A+ reputation doesn't mean that that's going to be the provider for you.
Right.
Yeah. So
in other words, shop.
Exactly. Yeah. Shop. Yeah. Do the interviews.
Yes.
Call. Office staff is everything. How they're going to, their team is actually disseminating information to the provider.
Yes.
How quick does that happen? What does response time look like? And some things are unavoidable because we know that a lot of our providers now are under these corporate healthcare systems.
Okay.
So they have certain criteria, the checklist.
Yes.
Right?
Yes.
And so they're running like these checklist practices, unavoidable. Because if I sold my practice to a franchise, a healthcare corporation, then I have to follow what the checklist process is.
Right.
So
It's almost like an assembly line.
Assembly line medicine. And it's recognizable.
Yes.
Sometimes. I mean, if you come from like way back when they would come in actually with a chart and look at you and that type of one, I'm just typing all this data into a platform.
And I think I even seen something like that on TikTok. The doctor walks in, you're sitting over here, the doctor's over here, and the whole time you're talking, the doctor's not even looking at you. They're just over here just typing on the computer. Yes, you're right. No, look at me.
Right.
Look at me. Talk to me. Hello, I'm over here. Yes.
You're just constantly entering information into that platform and database because now they're on metrics.
Yes.
Right?
Yes, they are.
How many patients I need to see per, and those blocks are opened up with specific times and all. So it's all of that going on. But yeah.
You're right with yes. Yeah. Metrics meaning yes, we got to see so many patients in so much time. Like they have time slots. And I think because I remember back when, I think time slots was 15 minutes.
It's 15 minutes, yeah. 15 minutes, and a physical could be 30 to 45.
Right. So
some offices are gracious enough, they'll block off that whole hour. But depending on which platform they're using and what that healthcare corporation, what metrics they've set out, then that could look a lot different in a lot of different places.
Right, and that's where the double booking and the triple booking comes from.
And overall, they tell you if you arrive to the office 15 minutes late, you'll have to reschedule.
Right.
But you can arrive there 15 minutes prior to your time and not be seen until 45 minutes later.
Yes.
And don't ask any questions. Right?
You're going to get the face.
All of that. So, but I think it's important to shop because you will have to filter through some of that.
Yes.
Unfortunately, sometimes it's unavoidable.
And the other thing is, too, is that even I feel like this. If a doctor tells you something and they give you a diagnosis, if you do question it, and it's okay to question it.
Yeah.
It's okay to question it.
Yeah.
It's okay to say, you know what, I'm going to go get another opinion.
Yeah.
Or I'm not going to go to Dr. Smith because this doctor told me to. You can go to whoever you want to.
Yeah. Yeah, that's true.
You go to whoever you want to. Who do you think, again, is good for you? Don't just accept what they say.
Yeah.
And also, too, read up on it. If you get a diagnosis, read up on it. I know they don't like us to do that. Read.
Yeah, read so that you can have conversation. You want to have dialogue.
Right.
And
you
can
understand.
To understand. And then sometimes you're leaving that office with all that information. Now you have to take it home maybe to your spouse or your children.
Right, and try to explain.
So you want to ask questions. You want to be able to do your research. You want to make sure that any resources that are available, some of the associations. For example, there are all these like cancer associations, Alzheimer's associations. You want to be able to make sure that if there's any resource available, like get that, any research.
Yes.
Right?
Yes.
And really do a deep dive. And I know they don't like us to use like internet medicine, like WebMD. But you shouldn't use it for like self-diagnosis.
Right.
But it's okay as a resource because it gives opportunity for the layperson, the non-clinical person, to be able to have discussion and ask questions.
Yes.
And that doesn't mean you take your WebMD profile in and you're going to tell your provider that this is what it is. But that resource allows opportunity to open up discussion. Because some of the verbiage could be something that you've never seen before. And there's this thing that says, most patients get their first experience into healthcare under an emergency situation. And so your first experience can be pretty scary if your first experience or introduction into healthcare is through the emergency room.
Okay.
And so you haven't had time to really digest and understand what this whole system is about, right? So something happens to me traumatic, or I have some type of circumstance, some symptom, and now I end up in the ER, and now I'm admitted, and now it's a long-term
process.
I got to go to rehab, and I have to go. So that's what we mean when we say most patients are introduced into the healthcare system through some type of emergent situation, trauma, something traumatic that has changed my total life. Right? Changed my trajectory.
Right, and then all of a sudden you're
healthcare, and there's all this stuff coming at me.
Right.
So it can be a bit overwhelming.
Yes.
which is why it would be helpful to have like a partner.
Yes.
And then we have to think about some of these, the breakdown where we really have an already compromised healthcare system. It's overwhelming. Since COVID, a lot of people don't want to do hands-on care anymore.
Exactly.
In the nursing industry, providers, like people at that level, it's limited.
Yeah.
And then now that we're not professionals anymore, the mindset that people have when it comes to hands-on patient care is totally different.
Right. Right.
And so the system is already compromised, and now you have to, or for the person that now has to be introduced into a system that's already struggling and only to get more disenfranchised, it makes it's a lot.
It is.
It's really a lot. So it's important to have conversations. One of the things that I really admire when I'm able to go into the homes of families and when we're doing like the training to show them like these specific skills that they can do at home and show them how to cut costs and show them that it's good when they say, I'm going to discharge your loved one home and they can just get 24-hour care. What does that really look like? And so most people say, oh, okay, that's fine.
Yeah, 24-hour care.
It's not free.
Right.
So there's a cost associated to that. And if you don't have long-term care, it can really be expensive.
Very.
Because you're paying out of pocket.
Very.
And so understanding, like the more skills that we have, I believe the more skills that we have individually ourselves, we can apply them.
Right.
So I've seen circumstances where family has a loved one at home, loved one needs 24-hour care, so they get round-the-clock care. Your night person is just sitting there, eyes on or not.
Right.
And you're paying that night person the same rate that you're paying the day person to do, right? Yeah. So it's understanding what it really looks like and what's specific for your family or your loved one during that process. Families like to sometimes have another family member sit in or something.
Yes.
And that's fine if you have another family member sit in and they just have eyes on, but also understand that if there's any like skill that patient is going to need,
they need to know how to do it.
They need to know how to do it.
They need to know how to do it.
And at minimum, CPR.
Yes.
At minimum.
Yes.
Shouldn't just have someone sitting there and
right, because it might be a situation where you have to turn the patient or
right,
knowing how to get the patient
out of the bed, right, adjustment, fall risk, and all of that. I mean, that turning at night is serious because skin breaks down pretty quick.
Yes.
So when you say to someone, hey, I need you to sit with my loved one at night, it's not just sitting there at night.
Right.
Like there's like a checklist
of things that need to be done still.
So it helps the whole.
Yes, because I think it's every 2 to 3 hours.
Every 2 to 3 hours.
Yeah.
No more, no less than 4.
Yeah.
Like 4 should be max.
It's a lot. But we say all that to say, get a book.
Get a book. I like the book. Get a book. Document everything. Doesn't have to be fancy.
No,
some people are really, and there's enough technology now. You can create a spreadsheet of all the things. If you're not like a written person, I believe in writing and taking that book right with me. But you can even use like a notebook, and when you're in and out of like provider spaces, have them print off what they said, what their care plan looks like.
And then you take it home.
And you take it home.
And you do a deep dive.
Yep. But definitely have something where you're documenting everything, because guarantee you, if you're using the healthcare system in any way, you're always going to have to go back and make reference to what happened before.
Yes.
Yeah.
Yes.
Yeah. It's a cause and effect.
Yes. Well, guys, we're getting close to the end. Salea will be back on. Okay. But before we go, Salea has to get a red velvet because, believe it or not, she has never had my red velvet. So we're going to let her have her red velvet. And while she does that, again, I want to thank Pam. Remember I said I can't go anywhere without my best friend because Pam does it for me. So without Pam, I can't do this. If you don't have Pam in your house, please get Pam in your house. Again, Pam is my best friend. But thank you all for joining Red Velvet Talks. Salea will be back on because clearly we have a lot more to talk about. She will be back on and we'll discuss a little bit more of being, more of an advocate and ways to really, really break it down for you all to understand, to make it easier for you when you're taking care of a loved one. And again, back to get a book. Just go to the store, buy a book, a journal, and just write.
Start there.
Start there. Pay attention to your loved one. If their hair is curled and their hair doesn't curl, you need to call your doctor
Yes.
and find out what's going on. That's what we mean when we say
Yes.
pay attention to the little things.
Yes.
You should know who you're taking care of, know everything about them, and treat them as if they are a newborn child. Because really, they, in a sense, if they're elderly, they are. And you have to pay attention to what's going on. But everyone, have a wonderful day. Thank you for joining Red Velvet Talks, and I will see you all next week. Bye.